Hey everyone, my name is Dr. Allison Hansen, and I'm the ultrasound director for the emergency medicine residency here at Tampa General, University of South Florida. And I'm here to discuss some point-of-care ultrasound cases with you. Point-of-care ultrasound can be used to assist in some acute care patient cases, such as undifferentiated dyspnea, chest pain, and hypotension. And we're going to speak about a few of them. So let's get started. Point-of-care ultrasound, as you may know, is used to answer very specific questions or a set of questions at the bedside, as opposed to comprehensive ultrasound examinations, which are ordered and performed in the radiology suite. Our goal with point-of-care ultrasound is to, again, answer a very specific set of questions or question to help us narrow down the differential in patient care. Point-of-care ultrasound differs from comprehensive ultrasound in that the individual who's performing the point-of-care ultrasound is also interpreting it and integrating it into medical decision-making. We love point-of-care ultrasound because, well, quite frankly, some of our physical examination components just aren't very sensitive, and POCUS, or point-of-care ultrasound, really helps to enhance that. And like I said before, it helps you narrow down the differential, what's happening with the patient at that moment. Our goal today is to go over a few cases. These are real-life cases, how you can integrate what we're going to teach you on our hands-on in November. Take that, integrate it to patient care at the bedside. And this is my son, Logan. He was born September 2nd. He's super cute. A frequent complaint that we hear from many patients, particularly in our line of work in the acute care setting, I'm short of breath. How are we going to take point-of-care ultrasound to assist in helping our patient in the hospital? But first, why do we want to incorporate point-of-care ultrasound for undifferentiated dyspnea? I already mentioned that our physical examination lacks sensitivity. Also, chest x-ray lacks sensitivity. Before COVID, I felt like we got a lot of two-view x-rays. And now, whenever I order a 2-view x-ray, I get a call from the technician asking me if that's what I really need. Do I want that? Can they come just do it at the bedside? And I understand they wanted to limit the spread of COVID, but 1-view chest x-rays are just not that good. And that's where point-of-care ultrasound comes in. It can assist you with various indications like diagnosing a pneumothorax, pleural effusions, pulmonary edema, a pneumonia, pulmonary embolism, asthma, and COPD. It has many limitations, particularly in our trauma patients, is subcutaneous emphysema. If somebody has a rib fracture, there is going to be subcutaneous air, and air is the enemy of ultrasound. You are just not going to be able to see anything past that sub-Q layer, as air just scatters ultrasound beams and they don't make it back to the machine to create an image. Also, obesity. When people have a lot of subcutaneous fat, it attenuates the ultrasound beams and you just can't see well deep to that. So let's talk about a real life case. You have a 65-year-old female with a history of COPD, ischemic cardiomyopathy, diabetes, chronic kidney disease. She still smokes quite some time. She's morbidly obese, and she was admitted from the emergency department for high-risk chest pain. When you go to visit her on admission day 2 to see if she's feeling better, see if she's ready to leave, she says no, she's actually feeling worse. She's feeling more short of breath with exertion, and she's been having a dry cough with her chest discomfort. You note that her vital signs are stable and she's not febrile, but her oxygen is low on room air at 91%, and she has wheezing in all lung fields. Labs are generally nonspecific, and you did get a 1-view chest x-ray, or somebody got it on her initial admission, which really was very poor in quality. She did not take a good deep breath, but there were no obvious consolidations. So you're wondering what you can do to enhance your evaluation here. Is that wheezing fluid? Is that wheezing COPD? Well, enter a point-of-care ultrasound. You go ahead and grab it, and this is what I do at the bedside. I bring it into the room when I'm evaluating the patient to save time, and I let them know what I'm doing. So while I'm talking to them, while I'm doing my physical examination, I start incorporating it. And you'll tend to just not use it if it's going to be extra work and extra time. Again, undifferentiated dyspnea, point-of-care ultrasound is great, and this is how you're going to work through your case of undifferentiated dyspnea. I do it the same way every time, and I always start with the lung, then my cardiac ultrasound, my IVC, and legs as needed. Legs, I'm looking for a DVT. Why do I start with lungs? And helps me differentiate between something like clear lungs or wet lungs. And that is going to help me narrow down my differential. Obviously, clear lungs, my differential is much bigger. But if I have wet lungs, I'm thinking some sort of like cardiogenic edema or infectious process. And then that's when you incorporate your history, your physical, the patient's IVC, and a DVT study as needed. I know that you guys talked briefly about the blue protocol in the previous video, which I hope you watched these videos prior to looking at these cases that I'm going through now. But the blue protocol is something that was developed by the father of lung ultrasound, Dr. Lichtenstein, and it was published in Chest in 2008 and has since been externally validated in some other papers, which you can find online. I recommend you take a look at it. There's a QR code here. If you just take a second and snap that with the phone, with your camera phone, it'll take you to this paper. This is the original paper. Now, if you've never read the blue protocol and perform lung ultrasound at the bedside, you undoubtedly are doing some form of this blue protocol without even knowing it. You are working through the patient's physical exam with the ultrasound and narrowing down the differential as to why they have acute respiratory failure. So again, this is a protocol that we kind of naturally do in whole or some part, but if you really want to get down to the nitty-gritty and the evidence behind it, take a look at this paper. All right, so we're still on our first case. We just have to do a little explaining and some pre-work just to make sure we're all on the same page. So when I grab my ultrasound on an undifferentiated dyspnea patient, I am undoubtedly starting with the curvilinear probe. Personally, I like this probe much more than any of the other ultrasound probes and looking at the lungs, because not only can I look for signs of wet lung, I can also look for lung sliding, and then I can look deeper, as this has a much deeper, it has a much wider field of view, and also the ultrasound beams go deeper. Their wavelengths are longer. If you had time to look at the physics lecture, you'd probably understand this a little better. So I grab my curvilinear probe, and I'm looking at each hemithorax, basically lawnmower through each lung field. Just make sure that you're looking at each side of the patient in its entirety. Now, I might go ahead and grab my linear probe if I can't seem to get a good visualization with my curvilinear probe of the pleura. Okay, the pleura is very superficial, and that's where the linear probe really shines. It will show you that pleural line with high definition, okay? But in my experience, the curvilinear probe is just as good, and that is the only probe you usually need when assessing lungs. All right, so let's go back to our case. Just in case you forgot, she was 65 years old. She's got a bunch of medical problems, lung and cardiac pathology. She was admitted for chest pain, high-risk chest pain rule out. You go and see her, and she is wheezy in all lung fields, and she's hypoxemic. You want to know what's causing her wheeze, hypoxemia, and shortness of breath. You grab your curvilinear probe. You're on your lung examination or your abdominal examination. Now, in the previous lung video, Dr. Daniel Embaum explained why each of them are beneficial when looking at the lungs. Remember, the lung, when you click your lung preset, that is going to show all the artifacts, particularly in a wet lung. When you click the abdominal preset and look at the lungs, that's going to hide those artifacts more, okay? But it's going to smooth out your assessment of other structures. So when you're starting out, you should practice using both presets. So here right now, we are on the abdominal preset. We have our rib here, and we have posterior shadowing, right? Because our bone is very dense, the ultrasound beams bounce off of it, and there is no ultrasound beams that make its way behind it. Okay, so it causes that shadowing. There is nothing behind there on your imaging interpretation. In between each rib, right, we have our pleural line right here. Do you see lung sliding? That's what I always ask myself to start. Is there shimmering of this pleural line indicative of the visceral and parietal pleural sliding across each other, which with inspiration? I definitely see lung sliding. I definitely see twinkling or ants marching, whatever you want to call it. There is lung sliding here. Is this lung wet or dry? So if you watch the previous video, you know that this horizontal line, this horizontal line, and so on are called A-lines. This is a reverberation artifact. Okay, this is basically just mirroring of this initial pleural line, indicating a well-aerated lung. Okay, there's no fluid in this lung. So let's say that you look through all lung fields and you see A-lines and lung sliding and nothing else. Right? So in this 65-year-old who is admitted for chest pain, who is has worsening shortness of breath and wheeze throughout on your physical examination and on your point of care ultrasound examination, she has good lung sliding or pleural sliding, A-lines throughout. What do you think is going on with this individual? And I know some of these cases might seem a little oversimplified, but this is just to hammer home the point of care ultrasound findings. This patient is having a COPD exacerbation. Case number 2 in undifferentiated dyspnea. You have a 65-year-old female, the same lady, same background medical history, admitted for high-risk chest pain rule out. You go see her on admission day number 2. She's saying that she actually feels worse. She's more short of breath, but now it's with exertion, and she has a wet cough. Vital signs are stable. She has some mild hypoxemia on room air, and you note some decreased lung sounds throughout. Labs were nonspecific. She did have a white count of 12,000, but you noted that she did get some steroids on her day of admission. Again, your one view chest x-ray just isn't very good. Maybe there's some haziness and bilateral lower lung fields. So while you're talking into her, performing your H&P, you let her know I'm going to be doing a point of care ultrasound to take a look at your lungs. And she is very excited and interested in your skill set. So again, you're looking at bilateral hemithoraces. You are lawn mowing throughout. So this is the right side. We have good pleural sliding. We know she doesn't have a pneumothorax in this lung region we are looking at. We do not see any B lines. In fact, we have nice A lines indicated well aerated lung in this area. But then when you get to the left side, there's a region that looks like this, right? We see sliding, but instead of A lines, we have these spotlights that are starting at the pleural line and going all the way down to the far field. This is the far field back here, right? This is the near field, okay? Here's your ultrasound probe and your ultrasound beams are coming out. These are called B lines, and they're indicative of wet lungs. Now, they don't tell you why the lungs are wet, right? They don't tell you if it's a transudate or an exudate, but this is not a dry lung in this area. So what's going on? We have pleural sliding, there's no pneumothorax, and we have focal B lines, right? Because we looked at the right side and there was A lines throughout, and then we go to our left side and there's this one region or quadrant, however you're breaking up that hemithorax, with B lines, all right? And this is in our patient who is admitted for chest pain, who had a negative chest pain workup, has COPD, ischemic cardiomyopathy, and she has a wet cough now and is short of breath. So what do you think is going on? This patient has pneumonia. Remember, B lines indicate there's a wet lung in that area, but it's not going to tell you whether it's cardiogenic edema, whether it is a transudate or exudate. This lady, who in this clinical context, our point of care ultrasound is pointing towards a pneumonia. Now, let it be known that pneumonia can take on various appearances when it comes to ultrasound. You can have focal B-lines like we saw on our previous slide. You could also have something that looks like this. This is lung. We have our curvilinear probe, and if you look at the depth, it's pretty superficial. This is a rib with shadow behind it. Here's another rib with shadow behind it. And in between is our pleura here. Now take a look at this pleura. It looks rather different than on our previous images or clips, right? It's kind of thick, it's heterogeneous. This is something called the shred sign. It looks shredded. And this is indicative of subpleural consolidations. In the right clinical context, this is a pneumonia, usually a more severe. And the reason that pneumonia can look different on ultrasound is it just depends on how long it has been dwelling and how severe it is, right? Sometimes it gets really organized and it starts as B-lines, and then as it organizes, it becomes more severe, and it can look like the shred sign, and it could even just cause complete consolidation of the lung, which we'll see next. This subpleural consolidations is something that we saw with COVID. This was noted as individuals were confined to their room with the first wave of COVID, and people were going in with just ultrasound so they didn't contaminate the technicians or their machines or the radiology department, and they were seeing this, a thickened pleural lines, subpleural consolidations. It's not specific to COVID, but this is one of the findings in COVID pneumonia. All right, so again, pneumonia can take on various shapes, sizes. Here is another finding in pneumonia, a more severe pneumonia, let it be known, on point-of-care ultrasound. Now, this is at the PLAPS point, which is basically the upper quadrants or the mid axillary line in the coronal plane. So here's our probe, right? This is the head, right? And I know that because here's our probe indicator that faces the patient's head. And here's our feet. What is this right here? That's our liver. On top of the liver is our very thin diaphragm. This is something unusual. It almost looks like the liver, right? It has the same kind of echo texture. There's some movement in it. So this is actually a pneumonia, and there's a very specific finding for pneumonia called dynamic air bronchograms. You can have static air bronchograms, which looks just like this, but there's no movement, right? This finding, if there's movement, is called dynamic air bronchograms. And basically, this is atelectatic lung filled with fluid in the alveoli. Okay, and this is air bubbles percolating in that fluid, usually a exudate, usually a pneumonia. Now, when the lung becomes atelectatic and it looks like the liver, we call that hepatization. That is a very well-organized pneumonia. Now, in this view, oftentimes we see the liver and the diaphragm, right? Again, here's the liver, and here's your diaphragm, usually in a well-aerated lung, and you see nothing behind it. When you see something behind it, that means that there's not air in there, because remember, air scatters ultrasound beams, and they just scatter into the atmosphere. They don't make it back to the probe for the machine to create an image, right? So it just looks gray. When the ultrasound beams have a medium to move through, they bounce off the spine and they head back to the machine, and you get this. You can actually visualize the spine. It's called the spine sign. So you know that there's something in that thorax that is not well aerated lung. It's either fluid, it's either atelectasis, it's something. All right. So in this individual, it is a pneumonia. Next case, still undifferentiated dyspnea. Same patient. right? She's still complaining. I'm sorry, same patient. She's 65 years old, still has the same lung pathology, cardiac pathology, admitted for high-risk chest pain rule out. You go and see her on admission day number 2. Say, are you feeling better? Are you ready to go? She says, no, I'm actually feeling worse. I'm short of breath with exertion. When I lay flat, I feel really short of breath. I have this nasty wet cough, and I feel like it's actually been going on for some time and it's worsened. On physical examination, you note that she has wheeze and rales in the lower lung fields, and now her SpO2 is 91% on room air. BNP was 500, otherwise her labs were untelling, and you get a really crappy one-view chest x-ray that doesn't really help. Maybe it's kind of hazy in the lower lung fields, but she did not take a good breath. You had reviewed her previous workups, as this is not her first time in the hospital, and you note that her last echocardiogram showed a ejection fraction of 55%. She does know that she has heart failure with preserved ejection fraction. So while you're performing your H&P, you take a look at her heart and lungs. But undifferentiated dyspnea, you start with the lungs. You want to know, are they wet or dry? So this is what you see. Again, you're lawn mowing through bilateral lung fields, and you note that she has B lines throughout both sides. There is no well aerated lung. And then you go to the PLAPS point. Remember, this is the posterolateral alveoli and pleural syndrome point. This is where you see the pleural syndromes and alveolar syndromes much better at this PLAPS point. Your probe is in the coronal plane. Okay? And what do we see here? Right? Here's our probe indicator towards our head. And this is towards the feet. Okay, down here. What do we see here? Here's our liver. Here's our diaphragm. What is all this? Anechoic area. That's fluid. That is fluid. Let's play it again. And what is this? Here, that is your lung flapping in the breeze, flapping throughout that fluid. That is consolidated lung, right? We call that the jellyfish sign. Again, we don't know if this is transudate, exudate, is this lymph, is this blood, but in the right clinical context, in this patient with ischemic cardiomyopathy, B lines throughout, no trauma, she has bilateral, let's just say you look on both sides and you see this on both sides, pleural effusions and pulmonary edema. What are you worried about in this patient? You're concerned that this is caused by an acute heart failure episode. So you know her lungs are wet, really wet, so you take a look at her heart. You want to know, is her ejection fraction now reduced? Because remember, she had heart failure with preserved ejection fraction. What do you think? This is a parasternal long axis, right? Here's our probe. This is what's closest to our probe, the right ventricle. Here's our septum. This is our left ventricle. This is our left atrium. This view, you can't see the right atrium. Blood is flowing through here, through the mitral valve, out the aortic valve, and then down to the feet. So this is our mitral valve here. This is our aortic valve here. Here's our mitral valve if you can't see my arrow. And you learned something called EPSS, right? You grab your M mode spike, you put it through the anterior leaflet of your mitral valve because you want to see E point septal separation. How far is our mitral valve separating from the septum? Right? During diastole. Remember, during diastole, that mitral valve should be swinging open and hitting the septum. What's happening in this patient? It definitely is not. Now, when you get more experience, you could just eyeball it and say, oh, that's definitely reduced. That's about 20%, 25%. I would say when you're first starting out, practice your EPSS. Throw the M spike over it, hit it again, and you get this nice waveform, okay, which is distance over time, okay? And it is basically plotting all the structures that this M spike transects. Okay, so when you put it over your anterior mitral leaflet, we can see how far it opens in relation and how close it gets to our septum. So here's our septum, and if we come across here, it's at about 5 centimeters. So this depth corresponds to this depth. So here's 5 centimeters. This is our septum, this hyperechoic line. This is our septum. Where is our anterior mitral valve? Well, we come over here. It's at about 8 centimeters. Here's our mitral valve. We know that it swings open and it closes. Open and closes, right? With systole and diastole, right? So it opens during diastole when it fills. How far away from it is your septum? So we're going to measure this distance. And if you recall, some people say normal 16, 17, 18, various resources give you a different number. I like to remember something I learned from Dr. Charlotte Durr, and it is a great way to remember what is normal. Sweet 16, okay? Or at least what is abnormal, let's say. Anything greater than 16 millimeters is severe systolic dysfunction, okay? This individual, EPSS, is 19 millimeters. Now, if you want to know how that correlates to ejection fraction, well, you were given this equation. You plug it in, all right? 75.5 minus 2.5 times your EPSS. 2.5 times 19, and that number minus 75.5 is 28%. And this EPSS is in millimeters, let it be known. So I would say, yeah, this is actually pretty accurate. I take a look at a lot of these, I eyeball it, and I would say, yeah, her ejection fraction was about 20% and pretty darn close, right? Remember, this was a 65-year-old female with wet lungs throughout, effusions, and now a reduced ejection fraction. Your suspicions are true. This patient needs to go to the CCU. She is in an acute heart failure exacerbation. You didn't need any expensive tests. You diagnosed this quickly at the bedside with point-of-care ultrasound. Oh, in case you want to take a look, this is her parasternal short. I encourage you to perform a complete examination. I'm not going to show you all of her cardiac views, but a great view to look at the left ventricle function, systolic function in particular, is the parasternal short. So you're in your parasternal long to start, probe indicator at the right shoulder. You rotate 90 degrees, probe indicator towards the left shoulder, and you get this nice kind of donut view of the left ventricle. You're slicing it in half. I believe in your previous video, they said stick your finger in the middle of it. Are all the walls thickening and thinning, coming in and out and close to your finger? That's how you can tell if there's any region that isn't moving, symmetric with the other areas, or in this case, there is severe global hypokinesis. This is a suboptimal view, and I intentionally put this up because I don't want to give you any false hopes. The majority of your views, not the majority, a good portion of your views at the bedside are going to be suboptimal. But the more that you grab the ultrasound and look at your patient's hearts, even in a normal evaluation, which I encourage you to do when you're first starting out, you'll be able to get, eventually, when you look at so many, you'll be able to gather information that you need at the bedside with these suboptimal views, the more you look at. So I encourage you to look at normals, abnormals, even if if you're not, if you don't feel qualified, or if you're not able to bill for them or integrate into medical decision making on your own yet, I would still encourage you to practice, and get as many images under your belt as possible. All right, so our patient, we know she's in acute heart failure. We looked at the left side of the heart to look at the systolic function. You can take a look at the right side of the heart. And I believe in our cardiac lecture, Dr. Charlotte Durr has shown you how to do that. Sometimes this can be rather difficult, Okay. It is sometimes hard to take a look at the right side of the heart with a point of care ultrasound, just because in general it's hard to evaluate and see. And we oftentimes get suboptimal imaging, particularly in a patient who's short of breath, sitting up, they can't change positions for you. So a good surrogate for right-sided pressures is taking a look at the IVC. Your IVC is directly connected to your right atrium. So we want to know, right? We're at point of care ultrasound, we're just answering basic questions. Is it plethoric or is it thin, right? What's going on with the right side of the heart? In this patient, what do you think? This is the IVC here, and we see it dumping into the right atrium here. I would always encourage you to get this view. Don't call something the IVC unless you see it dumping into the right atrium, because it's quite easy to misinterpret the aorta as your IVC. Okay, the aorta actually goes behind it. We don't see the aorta here. What do you think about this? Is the IVC thin and slit-like? Is it collapsing with our respirations? Or is it kind of big with minimal collapse? Well, you can measure it and you can also eyeball, right? This individual's IVC looks pretty big, and I can see that there is definitely less than 50% collapse with respirations. I would encourage you, when you're first starting out, measure, right? The IVC is great. It is kind of controversial, looking at the IVC solely for purposes of answering some questions. So that's why you always incorporate the IVC into other examinations, heart, lungs, IVC, and other images if you need them, but always use the IVC. Don't use it solo. It should be incorporated into a more a global assessment with point of care ultrasound of your patient. And another thing is IVC has great sensitivity when it is really small or really big. Okay. In the middle, it's just not very helpful. So this patient's IVC is 2.6 centimeters and it has less than 50% collapsibility. That's indicative of elevated right-sided heart pressures. Okay. This patient is fluid overloaded. On the left side isn't functioning well, and we know that the right side is also experiencing significant pressures. This patient needs to be diuresed, sent to the CCU, and obviously needs a further workup for new onset heart failure, heart failure with reduced ejection fraction. All right, great. Next case, same patient, 65 years old. She still has a lung, heart pathology. She's still morbidly obese. She was admitted for high-risk chest pain rule out. On admission day 2, you go to say, are you feeling better? You ready to go home? And she tells you that she's actually no worse now. She's short of breath, and she has lower extremity edema, worse in her left leg than her right. You notice that her vital signs have changed. She's now hypotensive and tachycardic with mild hypoxemia on room air. You auscultate and you actually hear good lung sounds throughout. Labs were generally nonspecific. One view chest x-ray didn't help you necessarily. It was a very poor inspiratory effort. And you went ahead and ordered a lower extremity DVT ultrasound. That's not going to happen for quite some time. While you're waiting for that and speaking with the patient, you go ahead and grab your point of care ultrasound to help answer some basic questions, right? Again, is there lung sliding? Are there findings of pulmonary edema? Do I see effusions? So let's get to it. So again, you're going to look in bilateral lung fields. Is there lung sliding on this patient? Do we see twinkling, movement at that pleural line? Yes. There's no pneumothorax in the lung fields where you see this. All right. Our second question, are the lungs wet or dry? Well, they're definitely dry. We have our nice A lines. There are no B lines. Our lungs are dry. And let's just say that we looked at bilateral lung fields, okay? So there's pleural sliding in this patient, and there's dry lungs throughout, okay? So remember, she was hypotensive, tachycardic, hypoxemic, had unilateral leg swelling, all right? So we know that there's no pulmonary edema, right? This is less likely a CHF exacerbation. There's no findings of pneumothorax. We don't see any focal consolidation, hepatization, dynamic air bronchograms, focal B lines indicative of a pneumonia. So what are you worried about in somebody like this? Well, I would personally be worried about venous thromboembolism, right? So the next thing I'm going to look at, because the lungs aren't really helpful, well, they are helpful. They told me she's not having cardiogenic pulmonary edema or pneumonia or pneumothorax, but I haven't really solidified my diagnosis just yet. So now, in somebody who's hemodynamically unstable, I'm going to look at the heart. This is a nice apical 4-chamber view. What do you see? How's the squeeze? How's the chamber size? Is there any fluid around the heart? Not the best view to assess systolic function, but in general, there appears to be, okay, thickening and thinning, right? Is there any fluid around the heart? I would argue yes. There looks like there's this thin anechoic area, so maybe minimal fluid, all right? It doesn't seem to be causing any significant pressure or collapse of the chambers that it abuts. All right, so small pericardial effusion. What's really striking to you? What really stands out is the relative chamber sizes, right? The right ventricle is definitely bigger than the left ventricle. That is absolutely not normal. A 1-to-1 ratio or anything bigger than that is absolutely abnormal. Usually it's 0.8 to 1 at its max size, right? And look at the septum. It's flat. Usually it has a little curve, right? The septum's flat, maybe even bowing into the left side of the heart. Definitely abnormal, all right? Indicative of elevated right-sided heart pressures. If we had a previous echo, I would absolutely look at it, make sure that this is not a previous finding. But let's just say in this individual, she had no right-sided heart dysfunction prior. Here's another view. That's our peristernal long. Now we're going to rotate 90 degrees, and here's our peristernal short. Again, big right ventricle, smaller left ventricle, flattened septum that's actually being pushed into the left ventricle, creating something called the D sign, right? This is indicative of elevated right-sided heart pressures. Little small effusion here. So our patient has pleural sliding, no pneumothorax. She's got dry lungs with A lungs in all lung fields, and she has new right-sided heart strain. This is a patient who was admitted for chest pain, is now hypoxemic, tachycardic, hypotensive, and has unilateral leg swelling. This patient has a rather large pulmonary embolism, and I would argue that it's probably not safe for her to go to the CAT scanner at this time, and she needs specialty consultation. And if there are no contraindications, I would have no problem starting this patient on anticoagulation. Now, once you guys get a lot of experience under your belt, you are definitely able to perform a DVT ultrasound at the bedside. Believe it or not, this is actually a rather easy evaluation that we do all the time in the emergency department. I don't think we're going to be able to teach you this on our hands-on day, but I will let you know that it is absolutely something you are quite capable of performing. All right, this is such an important question. Many RNs and other doctors, and even us, we ask ourselves this: do we want to bolus more fluids in our patient? Let it be known, like I had told you before, most of the time you need to do a multiple point-of-care ultrasound examinations to get the information you need. And in fluid status, that is no different. There is no single point-of-care ultrasound evaluation that's going to be better than another, okay? So you should be looking at multiple regions on your patient, multiple organs, and considering all of that when assessing and making the decision to administer more fluids. Fluid status, just like with Undifferentiated dyspnea, I start with the lungs, I look at the heart, and then the IVC. Lungs, I want to know, are they wet or dry? If they have wet lungs, I'm not giving them more fluid. Absolutely not. If the lungs are nice and dry, then I take a look at the heart. Right? Is there systolic dysfunction? Is there something else going on? Then I look at the IVC. Why do we want to use point of care ultrasound for fluid status? Physical exam it's just not that sensitive. People can have chronic lymphedema. They can have really crappy lungs. It's difficult to really assess a patient's fluid status at the bedside. All right, here's a great case. See it all the time. 70-year-old gentleman admitted for urosepsis. He's got a history of non-ischemic cardiomyopathy with previous ejection fraction of 35%, high blood pressure, BPH. On the night of admission, you go to evaluate him. He went to the floor. Now he's hypotensive and tachycardic. He does not look well. He's febrile and has a mild tachypnea. You suspect septic shock. He had already received 30 cc's per kg of lactated ringers in the emergency department, and the nurse is asking you, do you want more fluids for this individual? You grab your point of care ultrasound and you go to work. You take a look at his lungs. This guy has a cardiomyopathy. Is he in acute heart failure? Is there fluid in his lungs? Right? He has great pleural sliding and he has nice dry lungs throughout. Let's just say you see these nice A lines throughout all lung fields. Now we're going to look at his heart. He has a previous ejection fraction of 35%. We just like to get a general overview of the systolic function of the heart in our fluid status evaluation. So you're going to do your EPSS, or like me, eyeball it. But for you starting out, I would recommend you do your EPSS. Systolic function, I don't know, I'd say it actually probably looks a little bit worse than 35%. So I am on high alert. Patient has poor systolic function, but we know that he's not in acute decompensated heart failure as he does not have any pulmonary edema at this time. So now let's look at his IVC. We know that his systolic function really sucks. So the left side of the heart function is probably at its baseline. It's not causing any acute cardiogenic pulmonary edema. But remember the right side of the heart. We don't know anything about his right heart status. What do you think about his IVC? Is it dilated? Is it thin? How's the collapsibility? Is it 50% and less? Yeah. He has a dilated IVC with very minimal change during respirations. There's something called fluid tolerance and fluid responsiveness. Fluid tolerance is an emerging concept we're going to talk about, but fluid responsiveness, you probably hear a lot of. Fluid responsiveness is when a patient can take the volume, give them, and increase their cardiac output. Fluid tolerance is, can they accept that fluid on the venous side of things, or does it cause organ dysfunction downstream from the heart, like a congestive hepatopathy, nephropathy? This is something we really failed to recognize, I believe, anecdotally in the emergency department. We give fluid to any individual as long as we don't think their lungs will be compromised, not assessing if they would tolerate it. Now, I don't hear a lot from the ICU doctors coming down on the emergency department saying, hey, this patient went into kidney failure from too much fluid administration by us. But I do believe it likely does happen. Too much fluid administration, or more likely, are going to have some organ dysfunction from venous congestion later on. All right. So this individual, they have good pleural sliding, they have dry lungs, they have reduced ejection fraction, which we know about, but they also have a dilated IVC, increased central venous pressures. They're likely going to be fluid responsive. I'm going to give them some fluids. The amount I'm going to be very cautious with. I would highly recommend that you take a look at this paper, and it is all about the emerging concept of fluid tolerance. Scan this QR code and it will take you straight to it. After you read it, I really highly recommend that you go down to the supplemental Appendix A, and it is a bunch of case examples by this gentleman, Felipe Rolla. They're really good, and it really helps you solidify the concept of fluid tolerance. All right, Another common complaint, we have a few more cases to get through. My chest hurts. I'm short of breath. Chest pain and dyspnea, I again go through the same evaluation. I start with the lungs, the heart, the IVC, and if needed, I do a DVT evaluation. So let's say we have a 35-year-old female this time. She smokes, she has lupus, she has chronic kidney disease, refractory hypertension, morbid obesity. She is on oral contraceptives, and she was admitted for intractable chest pain. She does not take her home medications. Labs were untelling. Chest x-ray had mild blunting. EKG was non-ischemic, and her dimer was negative. Tropes, negative, BNP 300. She was admitted, and that night of admission, she started to develop worsening chest pain and dyspnea. She feels that the chest pain is worse, recumbent. You evaluate her with your stethoscope and note her lungs are clear, maybe a little decreased at the bases. There's no hypoxemia, but she went to the floor, and now she's tachycardic and she's hypotensive. X-ray was unchanged from the time she spent in the emergency department. So you grab your ultrasound to evaluate this hypotensive, tachycardic patient with dyspnea and chest pain. You evaluate her lungs. She has A-lines throughout, good lung sliding, but this is what you see at your PLAPS point. This is bilateral pleural effusions. Now you take a look at her heart. How's her ejection fraction? Well, we see that mitral valve slapping the septum. I would say it's really good, maybe a hyperdynamic. But what do you see that's alarming? Especially in this case presentation. We see a pericardial effusion. And we know it's pericardial because it goes in front of the descending aorta. Now, something that I want you to be able to perform at the bedside, an evaluation for tamponade. And in this patient who's hypotensive, tachycardic, short of breath with a pericardial effusion, this is the first thing that I'm going to be evaluating, right? I want to know if that fluid around the heart is causing tamponade. Now, we did see she had bilateral pleural effusions, and you might think, well, surely that could be the cause for her symptomatology. Well, maybe the dyspnea, but in the absence of trauma, that fluid in her lungs is unlikely blood. That's not going to cause her hypotension. But I would be worried that the fluid around her heart definitely could. Okay? So, how would you evaluate for tamponade at the bedside? It has actually something fairly easy, and you already know how to do it. You're looking for one of the earliest signs of tamponade. One of the earliest signs of tamponade is right ventricular diastolic collapse. And I'm going to show you how to do that. You recall how to perform E-point septal separation with your M-spike. You're going to do the same thing here when assessing somebody from tamponade. You're going to have your parasternal long axis. You're going to put your M-spike over the mitral valve leaflet. And we want to know, during diastole, is that right ventricle free wall collapsing? This is how M mode can help you assess that. You throw your M spike on, you hit it again, and you're going to get this beautiful waveform. This looks familiar, right? Where is my mitral valve? Here's my mitral valve at about 8 centimeters. Here it is, right? Opening, closing, opening, closing. Here's my septum at about 6 centimeters, right? Here's my septum. But instead of assessing if my mitral valve is hitting my septum and how far away from it is, right? We don't care about that. We don't care about the ejection fraction necessarily in this patient. We already qualitatively assessed it and it was normal. We want to know if during diastole, which is when this mitral valve is open, hitting the septum, what is the right ventricular free wall doing? Where's my right ventricular free wall? My right ventricular free wall is here, right? Here's my probe. Here's my subcutaneous area. My right ventricle is closest to my chest wall, closest to my probe. Here's my RV free wall. It's about 2 to 3 centimeters. Here we go. This is my right ventricular free wall. So during diastole, mitral valve's open. We come straight up to our RV free wall. Is it bowing in? Is my free wall bowing in during diastole? Yes, it sure is. Send these pictures to CT surgery. They will be right down for this patient. You can call them and say that you see right ventricular diastolic collapse. This patient has early tamponade. I would not send this patient to the echo lab. I would encourage cardiothoracic to come and take this patient to the OR emergently. Another finding in tamponade, so we said one of the earliest findings is right ventricular diastolic collapse, very specific. One of the most sensitive findings is IVC dilation. Here's our heart, here's our fluid, here's our dilated IVC. Now, not very specific, right? Because people can have a dilated IVC for other reasons. In majority of cases, 99.9999% of patients, they will have a dilated IVC. You might have a strange situation where somebody's so severely dehydrated and also has tamponade, or they're bleeding out and also has tamponade. Say somebody collapsed in their home and laid on the floor for 3 days as fluid accumulated around their heart. Yes, you could have a smaller IVC. But in the majority of cases with tamponade, they would have a dilated IVC. So again, this patient with lupus, not taking her meds, bunch of other medical issues, coming in with chest pain. You know, she had bilateral effusions, indicative of fluid in her lungs. She had no signs of pneumothorax, so you had a reason for her to be dyspneic, but you didn't have a reason for her to be hypotensive. You noted that on your cardiac exam, she had fluid around the heart, and when you performed your M mode evaluation, she had right ventricular diastolic collapse, indicative of cardiac tamponade. You called CT surgery, they took her to the OR. This is a great example of how point-of-care ultrasound can really expedite patient care. All right, one more case. 70-year-old female admitted for COPD exacerbation. Overnight, she was complaining of chest pain and became more dyspneic acutely. You get in there, nurses call you in, you place her on BiPAP for tachypnea. You note that she's hypoxemic as well. Inline nebs are started. You get an EKG. You note there's no ischemia or changes. Blood pressure is 166/96. She's also tachycardic. Oxygenation improves on the BiPAP. You try to take a listen to her lungs, but it's really hard to auscultate. It's so loud in there, and the BiPAP is really loud. So you call for a stat chest x-ray. They said they'll be there as soon as possible. She's looking pretty sick. So you grab that point-of-care ultrasound to assess this patient to try and figure out why she's so acutely dyspneic, why she has acute respiratory failure, because you want to answer those simple questions. So this is what we see. On our right side, is there lung sliding? Here's our pleural line. We see nice twinkling. Yes, there is lung sliding. So there's no pneumothorax on the right side of this chest wall. Here's our left side. What do you think? Is there a lung sliding? Here's your pleural line. Here's a rib. Here's your pleural line, a little harder to see. Do you see that twinkling? Do you see movement at that pleural line? At the bedside, you're like, whoa, I don't think I see any lung sliding. But you're not feeling very confident about your point-of-care ultrasound just yet. So you decrease your depth and you take a look again. Here's your pleural line. You say, gosh, I just don't think I see lung sliding on that left side. Still not feeling confident, you go ahead and grab your linear probe. Here, you see two ribs with shadowing behind them. Where's our pleural line? Is this it? Or is it farther down here? Well, I don't want you to mistaken the intercostal musculature for the pleural line. You don't see the intercostal musculature, where my arrow is pointing at, when you use the curvilinear very well. But now that you have this high-def image, you can really see it has that striated appearance. So don't confuse the intercostal musculature with the pleural line, because the intercostal musculature is not going to move unless you're kind of pressing on it like this individual is here. So you don't want to accidentally get a false positive. The pleural line is deeper to the intercostal musculature. It's right here. There is no lung sliding on this patient. This individual who became acutely dyspneic, hypotensive tachycardic, has unilateral lack of pleural sliding, has a pneumothorax. And you don't need to wait for this chest x-ray to diagnose that. You call Pulm Crit Care, they come down acutely and start prepping for a thoracostomy tube. Finally, chest x-ray comes, and yes, you are correct. This individual has a left-sided, well, likely tension pneumo at this point, but left-sided pneumothorax. You didn't have to wait for chest x-ray to get specialty care moving. You diagnose it at the bedside with your point of care ultrasound. And just for comparison, you can see the bottom clip. We have our two ribs, our intercostal musculature, and just deep to that, we have our nice lung sliding, as opposed to our top clip, we see no lung sliding. All right, that is the end of all of our cases. Many other examples where point of care ultrasound of the lung, the heart, the IVC, and even the legs can really assist you in saving a patient time, money, saving yourself time, and really making some critical diagnoses without waiting at the bedside. This is in your wheelhouse. If you have any questions, you can always Epic Secure Chat me, Dr. Allison Hansen. I never sign out. You can also email me. I don't answer this USF email as frequently as I would Epic Secure Chat. So, questions about cases, images, examinations, anything when it comes to point of care ultrasound, please reach out to me. Thanks.